This talk is to cover a major joint in MSK, which is the knee joint. I give this talk to the residents all the time. And the other characteristic of the medial meniscus is that the posterior horn of the medial meniscus is significantly larger than the anterior horn, and this is very important when we look at the MRI appearances of the medial meniscus and we see a larger posterior horn but a smaller anterior horn. That does not necessarily mean there is anterior meniscal tear. It is just the appearance, the normal appearance of the medial meniscus. There are ligamentous attachments between the medial and lateral menisci. We have the anterior transverse ligament or the anterior transmeniscal ligament and the posterior transverse ligament. And these are very important for not to be confused with displaced meniscal fragment. We will see a few examples later during this talk. The medial meniscus is considered less mobile than the lateral meniscus because of the capsular attachment of the medial meniscus to the bone, and also because of the presence of the coronary ligaments of the medial meniscus here, the meniscofemoral and meniscotibial ligaments. They provide stability for the medial meniscus, and therefore medial meniscus is considered less mobile than the lateral meniscus. And because the medial meniscus is less mobile than the lateral meniscus, it makes the medial meniscus more prone to meniscal tears because it gets crushed in the knee joint during rotational movement of the tibiofemoral joint. And here again we see the lateral meniscus now, where the lateral meniscus is considered more mobile than the medial meniscus. But the lateral meniscus also has some ligamentous attachments, such as the ligament of Humphreys and Risberg, and these are meniscofemoral ligaments. In addition to these ligamentous attachments between the lateral meniscus and the femur, we have a few other structures that also provide some stability for the lateral meniscus, such as the popliteus tendon and the meniscofibular ligament. We see here the popliteus muscle and tendon wrap around the posterior horn of the lateral meniscus. And here we see the MRI appearances of the lateral meniscus with the popliteus tendon wrapping around the posterior corner or posterolateral corner of the lateral meniscus. And this is important, and we'll see examples of that because the presence of the interface between the popliteus tendon and the posterior horn of the lateral meniscus can sometimes be misinterpreted as meniscal tear, and that's because of the presence of the fluid in the popliteus tendon sheath. So you have the popliteus tendon, then you have the fluid of the popliteus tendon sheath, and then you have the posterior horn. Sometimes can be misinterpreted as a meniscal tear. This is referred to as a pseudo tear. Histologically, the menisci have three zones. They have the red zone, which is the peripheral zone, and it is called red zone because it is vascular. There are blood vessels within the lateral red zone. And then you have the red-white zone, which is the junctional zone between the red zone and the white zone. It is quite important to understand this concept of the histology of the meniscus, because tears involving the red zone of the menisci are often treated conservatively because of the healing potential for tears in the red zone. Because they are vascular, they are likely to heal. And if we detect tears in the menisci, we would normally describe whether the tears are situated in the red zone or in the white zone, because in the red zone, these tears tend to be left alone, not necessarily treated surgically. However, tears involving the white zone are often treated surgically by arthroscopy and meniscal trimming. And the reason for that is because the white zone is a vascular zone. There is no blood supply or blood vessels in the white zone. Therefore, these tears involving the white zone are less likely to heal, and therefore orthopedic surgeons tend to do arthroscopy and partial meniscectomy of tears involving the white zone. The blood supply for the menisci comes from the medial and lateral geniculate arteries. What is the structure of the menisci? The structure of the menisci are mainly the extracellular matrix and the interstitial water. The extracellular matrix constitutes mainly collagen type 1 fibers. And these collagen type 1 fibers are distributed in either circumferential or radial. So these are the circumferential collagen type 1 fibers, and then you have the radial collagen type 1 fibers. The appearances of the menisci on MRI, as I mentioned earlier, it is homogeneously hypointense on the short TE sequences such as T1 or proton density sequences. The menisci appear if you scroll through the sagittal plane through the menisci, whether the medial or lateral menisci. You initially start with a bow tie-like appearance, and then you get more of a wedge-shaped structure, and then you get a triangular structure. So that's how the meniscus looks like on the first slice, the second slice, and the third slice. Normally should have this appearance. And this is important to understand because the discoid meniscus will not demonstrate this bow tie appearance or the wedge-shaped appearance or the triangular appearance. On MRI scan, we see the same thing in sagittal PD fat saturated sequence. We see the lateral meniscus here, homogeneously hypointense. You get the bow tie appearance, and then you get the triangular appearance with the sharp free margin of the anterior horn and posterior horn of the menisci. So how do we describe meniscal changes? There is a system for describing meniscal changes. So for example, type 1 signal change. So this is how a normal meniscus looks like. It's homogeneously hypointense with no signal change within it. And then we have type 1 signal change is when there is like a dot of high signal intensity within the substance of the meniscus. This is considered as type 1. And then type 2 is when you see linear hyperintense signal intensity within the body of the medial of the meniscus, but without breaching the articular surfaces, whether the superior articular surface or the inferior articular surface. So this is considered as meniscal change. It's not considered meniscal tear. We will define meniscal tears in a minute, but it's quite important that we understand the different types of meniscal changes and which one we consider a meniscal tear and which ones we don't consider a meniscal tear. So this one is type 3, which is considered a meniscal tear because it's a fluid-filled cleft that is propagating within the body of the meniscus and then breaching the articular surface. So anything fluid-filled cleft that is breaching the articular surface, whether it's the superior articular surface or the inferior articular surface, is considered a meniscal tear. And then we have type 4 meniscal change, which is more ragged, more irregular, involving multiple, going in multiple directions and involving both superior and inferior articular surfaces. This is considered as a complex meniscal tear or type 4 meniscal tear. The criteria for meniscal tears, so we don't, as I mentioned earlier, we don't call all meniscal changes as meniscal tears. So criteria number 1 is abnormal signal change that involves the articular surfaces, but it should be seen on 2 or more slices and on 2 or more planes. So this is the definition of the meniscal tear. We do ask this question in the exam here for our students. The definition of the meniscal tear is that it's an abnormal signal or fluid-filled cleft extending to the articular surfaces on 2 slices and 2 planes. So for here, for example, here we have the sag planes, 2 images from the sagittal plane, and we have also the coronal plane demonstrating the same thing, the signal change. So this is a criterion number 1 for calling it a meniscal tear. Criterion number 2 is actually abnormal morphology or abnormal shape of the meniscus. in the absence of prior surgery. So if patient never had any meniscal surgery, such as partial meniscectomy, and then you look at the MRI and you see abnormal shape of the meniscus. So when you have abnormal shape of the meniscus, this indicates a meniscal tear in the absence of prior surgery. And when you have an abnormal shape like this, you should always be looking for a displaced meniscal fragment. And in this example, we see a displaced meniscal fragment in the anterior joint space. So that's a criterion number 2, abnormal shape of the meniscus in absence of prior knee surgery. Meniscal tears can be seen in different planes. So here, for example, we have a horizontal meniscal tear where there's fluid-filled cleft propagating through the body of the meniscus and surfacing in the inferior margin. So this is considered a horizontal tear. And then we also have vertical tears, and vertical tears could be vertical longitudinal, such as this one. And vertical longitudinal means the tear is extending along the entire meniscus. So this is considered vertical longitudinal tear. And also we have another example of vertical longitudinal tear involving the red zone of the posterior horn of the medial meniscus. And as we scroll through the images, we see this vertical longitudinal tear propagating along the body of the meniscus. We have another type of vertical tear considered the vertical radial tear, and this is how vertical radial tear looks like. On MRI scan, we see the fluid-filled cleft in the body or the free margin of the body of the lateral meniscus, and also we see here vertical fluid-filled cleft in the body of the medial meniscus, and also on the axial proton density fat-saturated sequence, you can still see the fluid-filled cleft, the radial tear involving the body of the medial meniscus. And as I mentioned earlier, complex tear means a tear in multiple directions. The other issue with meniscal tears is something we see commonly is a displaced meniscal fragment. The most common type of displaced meniscal fragment is what we call the bucket handle tear. And this is how a bucket handle tear looks like on this schematic representation of meniscal tear. And typically on MRI scan, what we see is what we call a double PCL sign. So this is characteristic appearance of a displaced bucket handle fragment of the medial meniscus. And you can also see the double PCL sign on the coronal plane, as in this patient here, for example, and you look at the coronal proton density sequence, and it looks like you have two PCL ligaments, but in fact, it's actually displaced bucket handle fragment. And one of the useful features for detecting bucket handle fragment is if you look at the body of the lateral meniscus and then you look at the body of the medial meniscus, the body of the medial meniscus is significantly smaller than the body of the lateral meniscus, and this is not normal. Normally, the body of the medial meniscus should be larger than the body of the lateral meniscus. So if the medial meniscus is significantly smaller than the lateral meniscus, in the absence of prior meniscectomy, then you should always be looking for a displaced meniscal fragment. As we see in this patient, we see a double PCL sign because of the bucket handle fragment in the intercondylar notch. And also on the axial plane, you can still see that displaced bucket handle fragment in the intercondylar notch. Okay, we have another case, if we have a candidate.
دكتورة شيماء علوان.
صباح الخير أستاذ.
صباح الخير.
We have sagittal MRI knee joint showing lateral meniscus. We saw here that the posterior horn of medial meniscus is migrated anteriorly into the anterior horn and show double delta sign, which indicate tear of the lateral meniscus.
Yeah, very correct. This is actually a tear of the posterior horn of the lateral meniscus. And what you see is complete absence of the posterior horn of the lateral meniscus. And these tears happen because of avulsion of the posterior root attachment of the posterior horn of the lateral meniscus. And what you get is an anterior displacement of the posterior horn, and sometimes referred to as the fast forward sign. Actually, this comes up in the OSCE exam in the Canadian board. And when I did the Canadian board exam, there was one case fast forward sign in the OSCE station. The other type of meniscal tears is what described as parrot beak tear. And parrot beak tear is actually a radial flap tear. So it's a radial tear, but it's not a radial straight radial. It's a radial with the flap orientation. So this is called the parrot beak. Characteristically, it's called the parrot beak tear. And also, sorry, we have another case here. If we have a candidate to look at these MRI images.
دكتورة إيناس.
صباح الخير.
صباح الخير.
Axial sagittal MRI of the knee at the level of medial meniscus, fat suppression sequence T2. There is يعني هو abnormal يعني configuration of the medial meniscus. The anterior horn is look smaller than the posterior horn. There is fusion, joint fusion. يعني المنسكس ده يبين إنه ماكو abnormal signal intensity. لا أكو vertical tear بالposterior horn of medial meniscus.
Yeah, do you know the term for this tear, meniscal tear? Do you know the name? Yeah, it has a special name to it. I don't know if you are familiar with it, but characteristically, this type of tear involving the do you know the name, the anatomical name of this part of the posterior horn of the medial meniscus? So this is the capsule here. Okay, posteromedial capsule of the knee joint, and this is the posterior horn of the medial meniscus. Do you know the name of the junction between these two structures?
Meniscofemoral ligament?
Meniscocapsular.
Capsular.
Yeah, so this is the capsule and this is the meniscus. So this is called meniscocapsular junction. So normally you should not really have fluid between the capsule and the meniscus. Yeah, remember what we said earlier, that the medial meniscus is more fixed and it's less mobile than the lateral meniscus. And the reason for that is because of the capsular attachment. So normally there's this capsular attachment of the meniscus, and that the capsular attachment keeps the meniscus fixed in its position. It doesn't move. And the reason why it does not move is because of the capsular attachment. And what we see in this patient is actually fluid cleft between the capsule and the meniscus. And we see it even more here. You're not allowed to have a fluid between the capsule and the posterior horn of the medial meniscus. That should not be there. There should be no fluid between the capsule and the medial meniscus. And the name for this one is ramp lesion. Yeah, so ramp lesion is actually far peripheral vertical tear of the posterior horn of the medial meniscus involving the meniscocapsular junction. This is a specific type of meniscal tear that can be seen in some patients, and the name for it is ramp lesion. There are certain types of meniscal tears that are considered unstable, and the stability question of meniscal tears is sometimes what orthopedic surgeons always look for. So what makes a meniscal tear unstable? If the meniscal tear is associated with a displaced meniscal fragment, it's considered unstable. If the meniscal tear is longer than 5 millimeters, is also considered unstable. If the radial tear of the meniscus is full thickness, which means it involves the entire thickness of the meniscus, is considered unstable. If the tear is present on more than one plane, it's also considered unstable. So these are the features of meniscal instability or meniscal tear instability which require orthopedic attention. Okay, do we have another candidate?
اوكي. ناخذ دكتور احمد. دكتور احمد.
نعم أستاذ. السلام عليكم.
تفضل.
نعم.
knee MRI, both coronal and sagittal plane tumor. there's يعني visualization of the meniscal body, thick and يعني persistent visualization the يعني meniscal body on both coronal and sagittal consists with the discoid meniscus involving lateral meniscus. Discoid lateral meniscus.
Yeah, perfect. It's a discoid lateral meniscus. So what are the problems with discoid lateral meniscus? Why is it important that we describe discoid lateral meniscus?
liable for يعني meniscal injury.
Yeah, so it is prone to degenerate or tear. Yeah, the only correction I would like to make is actually this is not a T1 sequence. This is coronal proton density sequence because we can see the joint fluid here. So yeah, so that's the only correction. But yeah, very, very, very good. It's a discoid lateral meniscus with no evidence of degeneration or tearing. Discoid meniscus is described as a continuous slab of meniscal tissue on 3 or more sequences on the sagittal plane. So if you scroll through the sagittal plane and you see slab of tissue like that, then it's a discoid meniscus. And the other criterion for discoid lateral meniscus is if you measure it, and if it is more than 13 millimeter in the mediolateral dimension from the lateral surface of the body to the tip of the free margin of the body. If it is more than 13 millimeter, then it's considered as discoid meniscus. The other thing we need to also comment on, and I mentioned this when we talked about the hip MRI and the hip labral tears. We talked about paralabral tears, and the same thing applies for the menisci. Sometimes you see parameniscal cysts, and it is again important to describe parameniscal cyst. And the reason for that is most of the knee surgery is done arthroscopically, and when surgeons examine the knee arthroscopically, they may not really be able to see anything that lies extra-articular. So a parameniscal cyst is something orthopedic surgeons don't really see when they do arthroscopy. And this is something we need to mention in our report so then they can actually decompress it or remove it surgically when they do the knee arthroscopy. MRI, sorry.
استاذ هارون، بس احنا اعتقد التايم مالت الزوم ميتنج حينتهي، فاحنا نقدر نطلع وحتى ندخل مره. اوكي اني؟
شكرا. Okay.
مره خاصه.
We stopped at the MRI. Yeah, we stopped at the MRI sensitivity for meniscal tears. So MRI is more sensitive for detecting medial meniscal tears than lateral meniscal tears, but still significantly high for either medial or lateral meniscal tears. What is really important about MRI scan, and this is what is important for orthopedic surgeons, is the negative predictive value, which is really high at 91%. MRI accuracy for meniscal tears is also high, is more than 95%, But that's if you use the rule we talked about. And the rule is that fluid filled the cleft, breaching the articular surface of the meniscus on 2 slices and 2 planes. So if you apply this rule, then your MRI accuracy should be more than 95%. But if you don't follow this rule, if you don't use the 2 slices and 2 planes, and you, for example, use 1 slice, then your MRI accuracy is really not that good. It's about 50% for medial meniscus and 30% for lateral meniscus. So that's why we emphasize all the time that when we describe meniscal changes, we have to make sure that we're seeing the meniscal changes on 2 slices and 2 planes. If I saw meniscal changes on 1 slice, then I would say in my report that the MRI accuracy for this meniscal change is 50% if it was in the medial meniscus, or I would say the accuracy is 30% if it was in the lateral meniscus. And the reason why I put this in my MRI report is because I don't want the orthopedic surgeons to do arthroscopy and then they don't see any meniscal change, and then they would consider it as a false positive MRI. So if I see the tear or the signal changes on 2 slices and 2 planes, then I just say meniscal tear. I don't really say anything more than that. But if I only found the tear or the signal change on 1 slice, then I have to sit on the fence. I have to say, well, it's 50-50. I'm not sure. It could be or it may not be a meniscal tear. I mentioned this earlier about the meniscal changes and the post-meniscal changes. The post-meniscal changes can be problematic for MRI. And the reason why, and we see this quite often in patients with prior meniscal repair, because MRI scan will demonstrate high signal intensity in the meniscus, even if the meniscus was repaired previously. And it could be a problem for the orthopedic surgeon. If you looked at the meniscus that had been repaired previously and you saw signal changes on MRI, then I would recommend you do CT arthrography. And the reason why you do CT arthrography is because CT does not have the problem of signal change. If there is a tear, then you will see contrast moving into the site of tear in the meniscus. But if there was no tear, then you don't see any contrast moving into the meniscus. So this is, I don't know how many patients you see with prior meniscal repair. In our practice, we do see quite a few patients with meniscal repair, and MRI can be a problem, and CT arthrography is a problem-solving tool here. The other thing about the meniscal tears is the pitfalls I mentioned earlier. And these pitfalls come from either the normal variants or the normal structures such as meniscofemoral ligaments, as we see in this patient here, for example. There is interfacing between the meniscofemoral ligament and the posterior horn of the lateral meniscus. And because of this interfacing between these 2 structures, it may be misinterpreted as a lateral meniscal tear, but actually, in fact, it's a normal variant here with that's sitting adjacent to the posterior horn of the lateral meniscus. The other pitfall is the anterior transverse ligament. And again, you get an interface between the anterior transverse ligament and the anterior horn of the lateral meniscus. So this interfacing can be a problem, but again, familiarity with this appearance would avoid any misinterpretation of these appearances. The other pitfall is the interface between the popliteus tendon here and the posterior horn of the lateral meniscus, which I mentioned earlier. So you get fluid here, but this fluid is actually in the tenosynovium of the popliteus tendon. As this interfacing between and may be misinterpreted as meniscal tear. Okay, do we have a candidate?
Okay. دكتورة
نعم.
لينا حامد.
أستاذ صباح الخير. Sagittal MRI scan of the knee joint showing thickening and abnormal signal intensity of the ACL ligament with the possible avulsion fracture of the tibial spine, suggesting ACL tear with avulsion fracture associated with soft tissue edema and possible joint effusion.
Okay, which sequence is this?
T1.
Yeah, it's T1 sequence because the fluid is dark.
Fluid dark, نعم.
Okay, so this is sagittal T1. Yeah, with avulsion fracture, very good. Avulsion fracture involving which bone?
Tibial spine.
Yeah, tibial spine avulsion fracture of the ACL. So now we finished with the menisci. Move on to the cruciates. The cruciate ligaments considered intracapsular but extrasynovial. This comes up in the multiple choice questions in the written part of the Canadian board exam. The anatomy of the cruciate ligaments, intracapsular but extrasynovial. The ACL resists the anterior tibial translation and also resists valgus and varus forces. ACL is also important for proprioception. The origin of the ACL is from the posteromedial aspect of the lateral femoral condyle, and then it inserts into the tibia at the tibial insertion. The ACL has two bundles. It has the anteromedial bundle and the posterolateral bundle. The tibial insertion of the ACL is always stronger than the femoral origin of the ACL. And this explains why most of the ACL tears we see are actually situated at the femoral attachment of the ACL. And that's because the tibial attachment is stronger than the femoral attachment. And this also of the tibial attachment because the bone is actually weaker than the tibial insertion of the ACL. So how does ACL look like on the short TE sequences, whether it's the T1 or the proton density sequences? It looks like a striated structure. It's not completely hypointense like the PCL, for example. The ACL has more striation to it. And the reason for the striation to it is because of the interlay, why it gives it that striated appearance. The ACL should always be parallel to the roof of the intercondylar notch, or what we call the Blumenstadt line. So this alignment between the superior surface of the ACL and the roof of the intercondylar notch is very important. We'll see examples later why this relationship between the ACL and the roof of the intercondylar notch is very important. As I mentioned earlier, the T1 is better visualized on the short TE sequences, the T1 and the proton density sequences. And you should look at the ACL in all the planes. You should look at the ACL in the sagittal plane, also in the coronal plane, and the axial plane. So here, for example, we see the ACL, the two bundles of the ACL quite nicely on the coronal proton density sequence. We also see the ACL and the two bundles quite nicely on the axial PDFS sequence. What are the mechanisms of injury of the ACL? There are three typical mechanisms of injury of the ACL. The most common one that I personally see in our practice is the pivot shift mechanism of injury. And this happens because of the rapid deceleration and twisting of the knee joint with valgus load and internal rotation. So this is how the pivot shift mechanism of injury looks like. So there is a rapid deceleration with valgus and rotation. What happens is the lateral femoral condyle dislocates and sits behind the lateral tibial plateau. And because of that dislocation of the lateral femoral condyle, you get this kissing bony bruise between the lateral femoral condyle and the lateral tibial plateau. So this is the typical appearance or the typical mechanism for ACL injury. and in the ACL. The other mechanism of injury is called lateral clip injury, is when there is direct force impacting on the knee joint from the lateral direction, causing valgus mechanism of injury. This is called lateral clip injury. How do we recognize ACL tears? We recognize ACL tears. The first sign of recognizing ACL tear is actually when there is absence of the ACL, when there is completely no ACL present in the intercondylar notch. And this one we see more often in patients with chronic tear, not acute tear. When there is chronic tear that has happened many years ago, then you get complete atrophy and disappearance of the ACL, and it's no longer present in the intercondylar notch. The second appearance for ACL tear is when it is more acute, and then you get fluid signal change involving the ACL. There is discontinuity, interruption, disruption of the ACL, and this is more acute appearance of the ACL tear. There's surrounding bone edema. There's also joint effusion. All these changes indicate more recent ACL injury. The other feature of ACL tear is the sagging of the ACL. Remember what we said earlier, that the ACL should be parallel to the Blumenstadt line or the roof of the intercondylar notch. And what we see here, actually, we see sagging of the ACL, and it is no longer parallel to the Blumenstadt line. So this appearance is more suspicious for partial tear or ACL sprain. It's different to this one. So here, for example, more of a complete tear of the ACL. But when you see the sagging of the ACL is more characteristic of ACL sprain or partial tear. The other appearance of ACL tear is when there is complete thickening and edema, when the ACL is thickened, more striated. This is more typical for ACL sprain injury. And the example we looked at was the avulsion fracture of the tibial insertion of the ACL when there's avulsion of the tibial spine, as we saw here. There are also secondary features that would suggest the presence of ACL tear, and these include bone contusion, especially with deepening of the lateral femoral notch or the sulcus sign. And here we also see, in addition to this osteochondral impaction of the lateral femoral condyle, we see edema. There's also edema involving the posterior aspect of the lateral tibial plateau. And the presence of this pattern of bony contusion or bone marrow edema indicates a prior pivot shift mechanism of injury. So what that suggests is that the lateral femoral condyle dislocated and was here at the time of the injury, but then relocated into its normal anatomic position. The other secondary feature of ACL tear is the question mark appearance of the PCL and also Sigonde fracture. And we see the bony fragment here of the proximal aspect of the lateral tibial plateau, which indicates a pivot shift mechanism of injury. The fracture itself is actually not significant. It's the association between the fracture and ACL tears that is more important. And the fracture happens because of the capsular attachment of the anterolateral ligament of the knee joint that leads to the bony avulsion injury. Another secondary feature of ACL tear is the anterior translation of the tibia in relation to the femur, and you get quite a bit of a gap here between the posterior aspect of the lateral femoral condyle and posterior aspect of the lateral tibial plateau. The kissing bony contusion I was talking about in the lateral femoral condyle and lateral tibial plateau due to prior pivot shift injury is also very important, suggesting associated ACL tear. The question mark appearance of the PCL is also another feature of ACL tear. So the presence of ACL tear, always when there is ACL tear, you should look for other pathology. For example, meniscal tears are coexist with ACL tear in about 60 to 70% of the cases. The O'Donohue's unhappy triad, which includes ACL tear, MCL tear, and meniscal tear. A posterolateral corner injury, we'll look at that in a minute, and the shear injury or the shear tear of the Hoffa's fat pad. All these are associated injuries that can be seen in patients with ACL tears. Okay, here we have another type or pattern of ACL tears, which are the partial tears of the ACL. To be honest with you, we don't quite quantify the amount of the ACL tear. There are studies that looked at the ACL tear and quantified them into less than 25% or more than 50%. I personally, when I see partial tears of the ACL, I either call them high grade or low grade. And the reason why I call them high grade or low grade, if I saw partial tear of the ACL, but the ACL is still parallel to the Blumensaat line, I call it low grade. If I saw partial tear of the ACL and the ACL is sagging, then I call it high grade ACL tear. ACL tears can also result in long-term complications for the knee joint, for example, and in some patients, even if they did not have meniscal tears at the time of the first injury, because ACL is a major stabilizer of the knee joint. If patients lose the ACL, then they will develop secondary meniscal tears because of the instability of the tibiofemoral joint. And also because of that instability, patient may develop osteoarthritis of the knee joint and ganglion cysts. Here we see an example of a patient who developed ganglion cyst of the ACL itself, which is actually a mucoid degeneration of the ACL, indicating prior ACL sprain injury. And also we see it here on the axial fluid-sensitive fat-saturated sequence. Okay, do we have a resident to take this case?
Yeah. دكتورة هويدة. دكتورة هويدة ويانا. دكتورة سرى خالد.
السلام عليكم أستاذ.
عليكم السلام.
Sagittal MRI fluid sensitive T2 signal showing fat suppression, showing abnormal يعني I didn't see the ACL and abnormal signal intensity of the Hoffa's fat pad with normal signal intensity of PCL but discontinuity at the femoral side. And also edematous bone marrow and that يعني of the proximal tibia. So with the complete tear of the ACL suggest.
Okay, so your conclusion now is, can you just summarize again?
Abnormal signal intensity بالbone marrow, abnormal signal intensity of the Hoffa's fat pad, and PCL discontinuity of the PCL suggests PCL tear.
Okay, can you, by the looks of this MRI image here, can you predict what mechanism of injury?
Lateral shearing.
Okay, all right. Okay, so we move on now to the PCL. Like you said, I mean, you are absolutely correct. There was PCL tear at the femoral attachment. So move on now to the PCL. Sorry, I don't know how to move this one. Okay. Yeah, PCL anatomy, similar to the ACL anatomy, as we said with the ACL, is intracapsular extrasynovial. Same thing applies to the PCL. It is actually the strongest ligament in the knee joint. It's stronger than the ACL. And it resists anterior translation of the femur or posterior translation of the tibia. Also resists valgus and varus mechanism of injury. It originates from the anterolateral aspect of the medial femoral condyle. Remember that ACL originates from the lateral femoral condyle, but PCL originates from the medial femoral condyle. The insertion is the posterior aspect of the intercondylar region of the tibia. Now, the PCL also contains two bundles, and these bundles are anterolateral and posteromedial. This is the opposite, completely the opposite of the ACL. Remember, with the ACL, we said anteromedial, posterolateral, but with PCL is anterolateral, posteromedial. So the bundles have completely the different terminology. Normal appearances of the PCL, it should look completely hypointense, homogeneously hypointense on the short TE sequences with no signal change in the PCL whatsoever. Remember, in the ACL, we said it's normal for the ACL to show striation with interlacing fat and vessels within the ACL, but that does not apply on the PCL. PCL has no striation whatsoever. It's completely densely hypointense. And same thing, you can look at it on the coronal PD sequence, and it looks the same, homogeneously hypointense with no signal change within it. And the mechanism of injury, the most common mechanism of injury for the PCL is actually the posterior translation of the tibia in patients with dashboard mechanism of injury, and that leads to the PCL tear. The other mechanism of injury is hyperextension and also rotational injuries. So when there is dashboard injury, then you get bony contusion involving the anterior aspect of the proximal tibia with the PCL tear. And this is the case that you looked at, PCL tear of the femoral attachment and bony contusion of the anterior aspect of the proximal tibia. And this is a typical dashboard mechanism of injury. The second mechanism of injury is hyperextension mechanism of injury, and this hyperextension mechanism of injury leads to kissing bony contusion involving the anterior aspect of the femur and the tibia. And this type of mechanism of injury leads to tears involving both the PCL and the ACL. So it's the one mechanism of injury that actually tears both cruciate ligaments. Types of PCL tears could be complete, partial, or bony avulsion, could involve the body, the femoral attachment, or the tibial attachment. Here we see a patient with PCL sprain. There is actually no disruption of the PCL. There is just signal change within the PCL and thickening and striation. So this is typical appearance of PCL tear, also a PCL partial tear or PCL sprain injury. And here the same thing. Here we see disruption of the femoral attachment of the PCL. So this is complete tear of the femoral attachment of the PCL. Here we see bony avulsion injury of the tibial attachment of the PCL. Same thing, bony avulsion injury of the tibial attachment. Okay, do we have a candidate to take this case?
اوكي ناخذ دكتورة دينا حمود.
نعم أستاذ، صباح الخير.
صباح الخير.
coronal section MRI T1. There is يعني abnormal signal intensity. هذا medial يعني medial aspect of the knee joint. يعني attached to the medial femoral condyle. وممكن يعني الابنورمال سيجنال بالميديال كولاترال ليجمنت. بدي اشوف انه اكو فد abnormal signal intensity بها.
Yeah, okay. Yeah, it's MCL. Yeah, sorry, go on.
العفو استاذ. يعني بدي اشوف انه abnormal signal intensity بالميديال كولاترال ليجمنت، يعني maybe medial collateral ligament injury.
Yeah, Yeah, perfect. The only correction I have that this is not T1. This is coronal PD because again of the fluid.
Density fluid, yes.
Okay, yeah. So yeah, there is medial collateral ligament sprain injury. So now we move on to the collateral ligaments, and we start with the medial collateral ligament. It's a strong flat band of tissue, and the main function of the MCL is actually to resist valgus forces on the knee joint. And it originates from the medial femoral condyle, and the insertion in the tibia is actually very distal, is about 7 centimeters below the level of the tibiofemoral joint line. So it's a very low insertion. It's the lowest insertion of any knee ligament. It's a very long insertion in the tibia. And it does have multiple layers. It has 3 layers. It has the superficial, the intermediate layer, and the deep layer. And knowing the anatomy of the MCL is very helpful because then you can actually comment on the MCL in terms of it's a partial tear, grade 1, grade 2, or grade 3, depending on these layers involved. These layers are also important anatomically because they fuse with each other. So the first layer and the second layer, when they fuse together, they form the medial patellar retinaculum. But then the second layer and the third layer, when they fuse posteriorly and they form the posterior oblique ligament. So this is also why you have, for example, the medial patellar retinaculum attached to the medial collateral ligament, and also the posterior oblique ligament attached to the MCL. There is also MCL bursa, so if you saw fluid within the MCL, may not necessarily be MCL tear, it could be just bursal fluid in the MCL. And so here how the MCL looks like: homogeneously hypointense, thin, flat band of tissue over the medial aspect of the knee joint. Mechanism of injury, the most common mechanism of injury is valgus stress mechanism of injury. That's normally how the ACL tears. There are associations, as I mentioned earlier, the O'Donohue's triad, where you get MCL tear, you get ACL tear, and you get meniscal tears. The grading of the MCL is probably the most reliable grading system for ligamentous injury. There is a clinical grading system and there is MRI grading system. The clinical grading system is a grade 1 when there is no laxity, but the patient is tender in the medial aspect of the knee. Grade 2 when there is laxity with endpoint. Grade 3 when there is laxity without endpoint. So this is the clinical grading system for the MCL injuries. The MRI grading system is also 3 levels. So grade 1 when there is signal change but no disruption of the MCL. Grade 2 when there is partial disruption of the MCL, and grade 3 when there is complete disruption of the MCL. So this is the MRI grading system for the MCL injuries. Now we move on to the posterolateral corner. So this is the list of the posterolateral corner structures. I ask the question all the time to our residents, radiology residents, about the posterolateral corner structures, and they only remember maybe 2 or 3 of these structures. But this is your full list for all the structures that are situated in the posterolateral corner structure, the posterolateral corner of the knee joint. And one of the ones that you probably will remember very well is the lateral collateral ligament, the biceps femoris, the popliteus tendon, the arcuate ligament. The other ones may not always be present. They are variable. Sometimes they are present, sometimes they are not present. But the constant structures, these are the ones that I listed just now. These are the constant structures of the posterolateral corner of the knee joint. The lateral stabilizers of the knee joint are the superficial structures, which include the iliotibial band and biceps femoris. The intermediate layer includes the patellar retinaculum and the lateral collateral ligament. And the deep layer, obviously, is the joint capsule. And these are the structures here. The lateral collateral ligament originates from the lateral epicondyle of the lateral femoral condyle and inserts into the styloid process of the fibula. The popliteus tendon originates from the popliteus hiatus, which is a groove here in the lateral femoral condyle. The arcuate ligament is actually a very interesting structure in the posterolateral corner of the knee because it forms a Y-shaped appearance to it. And the Y-shaped appearance to it comes from the lateral band, which is this one, that originates from the lateral epicondyle of the femur and inserts in the styloid process of the fibula. But then you have the medial band, which is this one here, which originates from the styloid process of the fibula and blends with the oblique popliteal ligament here. Posterolateral corner injuries are very important. They can be either isolated due to hyperextension or various mechanism of injury, but they can be combined with other knee joint injuries such as the ACL injuries or meniscal tears. So it's very important to, I always look at the posterolateral corner structures when I report an MRI scan, particularly if the patient had ACL tears or MCL tears. I always look at the posterolateral corner structure because they coexist with cruciate and medial collateral tears, particularly in patients with pivot shift mechanism of injury. Here we have posterolateral corner injury with bony avulsion of the ulnar styloid process. So you see this avulsion fragment. This is the biceps femoris muscle and avulsed the styloid process of the fibula in a patient with posterolateral corner injury. Same thing here, this bony avulsion we see of the fibular styloid process. And here we see tear of the fibular insertion of the lateral collateral ligament. There's discontinuity here and the fibular insertion of the lateral collateral ligament. And also here we see disruption of the femoral, the fibular attachment of the lateral collateral ligament. Here we see a patient also with posterolateral corner injury, but this injury now is involving the popliteus muscle. The popliteus muscle itself is very edematous with disruption also of the posterolateral corner structures. You see the arcuate ligament is very thickened and edematous, and that is in keeping with arcuate ligament sprain injury and associated muscle changes involving the popliteus muscle. And again, we see the edema of the popliteus muscle in patients with posterolateral corner injury. Okay, we have another case. If we have a resident.
اوكي ناخذ دكتورة نور عادل.
نعم أستاذ، صباح الخير.
صباح الخير.
Axial MR at the level of knee joint FATSAT T2 showing abnormal signal intensity involving the medial aspect of patella and lateral aspect of femur, suggesting dislocation, patellar dislocation. Location, dislocation and reduced to its normal place.
Yeah, so this is a prior lateral patellar dislocation. Probably the only thing you need to add is the presence of joint effusion.
Okay. Effusion, mild joint effusion.
Yeah. So bony contusion involving the medial surface of the patella, lateral surface of the lateral femoral condyle. So now we move on to the extensor mechanism of the knee joint. The extensor mechanism of the knee joint, these are the structures that involve the extensor mechanism of the knee joint. The patella, patellar tendon, quadriceps tendon. Quadriceps tendon is multilaminar because of the 4 tendons that form the quadriceps tendon. And then also we have the patellofemoral joint here. And this is the multilamellar appearance of the quadriceps tendon. So it's normal to have multilamellar appearance of the quadriceps tendon, and that's because of these 4 tendons that come together and form the quadriceps tendon. Patellofemoral joint is basically what you have is the medial facet of the patella, lateral facet of the patella, medial facet of the trochlea, lateral facet of the trochlea. You have trochlear groove, you have apex of the patella. All these together form the patellofemoral joints, and then you also have the medial lateral patellar retinacula and the medial patellofemoral ligament. Medial patellofemoral ligament is actually very important in any patient with lateral patellar dislocation. We should always comment on the medial patellofemoral ligament, if the medial patellofemoral ligament is intact or not intact, because for orthopedic surgeons, it's actually quite important to comment in the report on the medial patellofemoral ligament. So here we have the extensor mechanism, axial MRI, proton density sequence showing nicely the patellofemoral joint. We also see nicely the medial patellofemoral ligament, and here inserting in the medial femoral epicondyle. Remember what we said when we talked about the medial collateral ligament, we said layer 1 and layer 2. When they fuse together anteriorly and they form the medial patellofemoral ligament and medial retinaculum. So this shows you how these 2 structures, the medial collateral ligament and medial patellofemoral ligament, they actually are blending together here. And sometimes you see it in patients with medial collateral ligament tears. You see actually tears involving the medial patellofemoral ligament as well. The sagittal plane is really helpful to assess the relationship of the patella and relation or the position of the patella. So we always assess the patellar position, especially in patients with prior lateral patellar dislocation. We would like to assess the position of the patella by measuring the length of the patellar tendon and the length of the patella, and then we work out the insole salvati index. And this insole salvati index will determine if the patella is alta, which means high in position, or if it is patella baja, which is low in position. So a high patella or patella alta is associated with patellar dislocation and patellofemoral joint instability. So always if we have these patients with history of patellofemoral joint instability, we always measure the insole salvati index, and this is the way you measure insole salvati index on the sagittal plane of the knee joint. So yeah, patellar dislocation is basically lateral displacement or lateral dislocation of the patella, and can be associated with tears involving the medial patellofemoral ligament and bony contusion of the patella up against the lateral femoral condyle. Here we see example of patient lateral patellar dislocation and MRI image of that patient. Also, we see patients here with joint effusion and hemiarthrosis due to prior lateral patellar dislocation. This is the case that you looked at with bony contusion and joint effusion due to prior patellar dislocation. It actually comes up, this one in the OSCE. I had this one in one of the OSCE exams. In the board exam with this image, just one image on the OSCE station, and the diagnosis is a prior lateral patellar dislocation, or you can say recent lateral patellar dislocation. Again, another patient with lateral patellar dislocation, but there is disruption of the medial patellofemoral ligament here. Okay, so here not only lateral patellar dislocation, but there are features to assess why this patient had prior lateral patellar dislocation. And the reason why this patient had prior lateral patellar dislocation is what we call trochlear dysplasia. And trochlear dysplasia is when there is no trochlear groove. So normally there should be a groove here, the trochlear groove, but here what we have is completely flat patella. So the flat, trochlea. And because of that, we call it trochlear dysplasia. And this patient had lateral patellar dislocation and also suffered osteochondral injury here because of that dislocation. So when we look at patellar dislocation, we should always measure insole salvati index. We should always comment on the medial patellofemoral ligament. We should always comment on the presence or absence of osteochondral injury. We should always comment if there is trochlear dysplasia or not. So these are basically the things that we always mention in our MRI scan report. We should always list these ones because if patient has a trochlear dysplasia like this one, this patient may actually require medial application or medial stabilization of the medial patellofemoral ligament or medial capsule. So then this patient does not suffer patellar dislocation again. Okay, case number 9.
ناخذ دكتور سامر.
السلام عليكم أستاذ.
عليكم السلام، تفضل.
Multi or single size sagittal section of the knee joint with T2 and spare sequence show abnormal high signal intensity بالarea of the ACL with the increased thickness with the sign of the fluid collection and superior to the lower attachment of the ACL with high signal intensity بالposterior femoral capsule بالposterior femoral site or surface بعد يعني ماكو sign of there is هم the signal intensity of edematic signal bone marrow edema بالposterior upper tibial end. يعني الدكتور هذا اللي شفت ثاني.
Okay, so the history here is anterior knee pain.
Anterior
knee pain.
نعم. يعني suggestion بالنسبة لي دكتور أشوف إنه قد يكون عندنا بالنسبة للACL قد يكون احنا نقول partial tear or mucous degeneration. يعني بعد there is also an increase in high signal intensity بالlower patellar surface والlower inferior patellar ligament أو هم increase high signal intensity قد يكون في area of injury أو tear يعني.
Yeah, that's right. Yeah, actually, yeah, we're not really quite interested in the ACL right now because the history of this patient is anterior knee pain, and the changes are all here in the patellar attachment of the patellar tendon. So this is called jumper's knee. Jumper's knee is a condition that involves athletes or sportsmen who are involved in repetitive hyperextension of the knee joint, for example, basketball, volleyball, and soccer, football. All these types of sports are associated with repetitive overuse of the extensor mechanism. And what you get is tendinosis of the proximal patellar tendon. There is also small tear in the proximal fibers of the patellar tendon associated with marrow edema involving the lower pole of the patella. So all these changes altogether called jumper's knee or proximal patellar tendinosis with a small interstitial delaminating tear of the proximal patellar tendon fibers. And the other condition that may involve the extensor mechanism is Oshkosh-Slater disease, which is basically changes involving the distal fibers of the patellar tendon with small bony ossicles within it. This is an Oshkosh-Slater disease or prior. Sometimes you might also see bursitis involving the superficial infrapatellar bursa. All these changes together are described as Oshkosh-Slater disease. Another pathology may involve the middle segment of the patellar tendon. So this is mid-fiber tendinosis of the patellar tendon. Remember that the patellar tendon does not have a tenosynovium. So just like the Achilles tendon, the patellar tendon and Achilles tendon share a common histology, and they are the two tendons that do not have a tenosynovium. Okay, this may be our last case. Do we have a resident?
اوكي دكتورة فردوس.
صباح الخير دكتور.
صباح الخير.
عندنا two selected MRI section sagittal view T2 fat sat T1 abnormal signal intensity involving metaphysis of distal femur and abnormal soft tissue signal intensity بالhalf of bad sign بالpatello tibial tendon وبالquadriceps tendon also والposterior compartment اكو mild joint effusion هذا اللي دا أشوفه.
Yeah, okay, so your summary is?
يعني عندنا الباتيلو tibial tendon rupture وأكو tear بالquadriceps tendon also.
Okay, yeah, no, you're absolutely right. There's patellar tendon rupture. Do you know why this patient had patellar tendon rupture?
I don't have idea.
Okay, so you described the changes here in the femur. What do you
Yes.
think? What do you think this area is? This abnormal area is?
يعني contusion. أنا ما دا
Okay.
أشوف يعني segment يعني bone segment avulse mostly contusion.
Okay, so I don't know if you remember from the bone tumor talk we had. We said if there is an intramedullary lesion with geographic line.
Medullary infarction.
Yes, bone marrow infarction. So if we try and combine these together, bone marrow infarction and patellar tendon rupture, what do you think the cause of this patient's problem, to explain both?
يعني إنه ال patient a known case of sickle cell maybe.
Yeah, sickle cell may not necessarily have patellar tendon rupture, but there is a risk factor for both of these abnormalities in this patient. Yeah, someone messaged us here on the chat.
يعني overdose of analgesia.
Steroid, yeah.
Steroid.
Yeah. So this patient has had steroid therapy, and because of the steroid therapy, we have bone infarct and as well as the patellar tendon rupture. Okay, so this is a risk factor for both. All right, okay, so that was the patellar tendon rupture. Move on to the quadriceps tendinosis. Again, we see another patient with a quadriceps tendon injury and complete tear. And what we see here is patella baja, when the patellar tendon is actually, the patella itself is low in position, and that's because of the patellar tendon rupture. And sometimes if you do a knee x-ray and you see patella baja on the knee x-ray, always suspect quadriceps tendon rupture, especially if there is history of acute knee injury and loss of extensor mechanism. So should be always suspicious of quadriceps tendon rupture. Okay, so to summarize, what we talked about was mainly knee anatomy. We talked about the anatomy of all the knee structures, the menisci, the cruciates, collaterals, extensor mechanism. and also talked about some of the knee biomechanics and most common mechanism of injuries. For example, we said pivot shift injuries, the most common mechanism of injury of ACL tears. We talked about the MRI technique and the importance of having short TE sequence such as T1 or PD sequence because of the ligaments and the menisci that rely heavily on the short TE sequences. And we emphasized the definition of meniscal tears, and we said there are two criteria for describing meniscal tears. Criteria number one, when there is fluid-filled cleft in the meniscus breaching the articular surface, seen on two slices and two planes. So if that what you see in the meniscus, then the accuracy of the MRI should be more than 95%, i.e., if the orthopedic surgeons were to do a knee arthroscopy, in 95% of the cases, they will find a meniscal tear. And also we talked about the different mechanism of injuries for the cruciate ligaments, and also the value of describing the bony contusion. Sometimes the bony contusion is very helpful to predict what mechanism of injury the patient might have suffered. For example, we said lateral femoral condyle and lateral tibial plateau contusion would suggest pivot shift injury. Anterior contusion of the femur and tibia may suggest hyperextension mechanism of injury, and so on and so forth. So if you really want to know the mechanism of injury of the knee joint, just look at the bony contusion and the pattern of bony contusion. That should really help you understand the mechanism of injury and what structures may have been torn because of that mechanism of injury. Okay, do you have any questions? If you have any questions, please go ahead.
شكرا جزيلا أستاذ هارون for